we have invited two of our expert cardiology researchers from the Radcliffe Department of Medicine at Oxford University to talk about their latest research on this very interesting women's health topic and is specialising in postpartum health. I'd like to introduce Dr. Jamie Kitt and Dr. Winnock Lapidaire. Jamie is a consultant cardiologist in London and Oxford and is conducting postdoctoral research into hypertensive pregnancy. And Winnock is principal investigator in cardiac medicine. Her research focuses on the effect of high blood pressure on the brain, especially during and after pregnancy. So I will now hand over to Jamie. Thank you very much.
I'm going to try to keep this as informed as possible. I call myself Jamie. And first of all, just starting with a bit of background to why Winnock, myself, and the group within the Radcliffe Department of Medicine are researching this area. And first of all, hypertensive disorders of pregnancy, which cover a spectrum of conditions, including gestational hypertension, preeclampsia, principally, but also if you've got high blood pressure and then get another condition superimposed, are very common, affecting over 10% of people globally, and more common than that if you're African or Caribbean, up to 15%. A third of these women will come back with permanent high blood pressure within 10 years. And not only that, but there's a significant increase in the risk of having other disorders of the heart, including heart attacks, heart failure, where the pump isn't working properly, and problems with the heart valves, including a leaky valve and narrowed valves. There's also risks in the brain, and Wendy's going to talk more about those later, and those include doublings in the risks of stroke, vascular dementia, and also early degeneration in the kidney function. Prior to the work that we did in Oxford, there'd be lots of observational studies showing that there were these risks and trying to make people aware that there would be no proven intervention prior to the trials that could hopefully make a difference. And that's why we're talking to you about this today. So why did we do the particular work that we are going to present to you today? So we had noted, I'm going to say we, the royal we, Paul Leeson's the senior investigator in our group for both Winnock and I work, and he noted with some other students doing their PhDs that if you have high blood pressure during your pregnancy, your heart becomes thicker, it becomes less efficient in terms of its function. Whilst these changes are seen to a lesser degree in a normal pregnancy, in normal pregnancies, this all returns to normal once the baby's delivered within a few weeks. In those who've had preeclampsia or gestational hypertension, however, over 50% had abnormalities in their heart structure and function at 6 weeks to 6 months. A big group in Georgia showed this as well as some groups in America and Australia. And we followed these women up for 10 to 20 years and found that if your heart was abnormal in that early period at 6 weeks, 6 months, you were much more likely to have a problem longer term, such as heart failure or a problem with the heart valves. We then worked with another professor, primary care, or Richard McManus in Oxford, who'd done some excellent work showing that if you improve your blood pressure by allowing patients to manage their blood pressure guided by a doctor after they've had a stroke, you improved outcomes after stroke. We wondered if we did this with preeclampsia and gestational hypertension, would we see the same thing? When to intervene? One of Paul's default students had tracked women. Don't worry about the detail of this graph. What it's showing is different types of preeclampsia early in the pregnancy, around 20 weeks, and then later after 36 weeks, and then normal pregnancy going from the top to the bottom. But whichever group you're in, your blood pressure around 6 weeks tracks your blood pressure in later life for about a decade out. And therefore, we thought this could be the period we could intervene straight after birth when you're home from hospital, where we could potentially alter your long-term trajectory. So we wondered, these are essentially our hypothesis, if we improve blood pressure control in this period, could this not only improve blood pressure control, but also bring the heart shape and function back to normal, like a normal pregnancy, which in turn may reduce the risk longer term of heart failure and heart attack? Could we influence the brain in such a short period of time? And could Richard McManus's self-management techniques he piloted in stroke be the ways through which we could achieve this? So the initial work was done by Alexandra Kens, who's an obstetrician now within Oxford, and she wanted to show that this technology, this self-management, which is where women are allowed to monitor their blood pressure guided by a doctor, either uploading it via an SMS or in the later studies using slightly more modern technology and automatically uploading from the monitor to a computer which feeds back And essentially what Alex did in just tried 100 people was she showed that this was safe, effective, and liked by women. And not only did it have those benefits, but actually when we look at 3 months, when the vast majority of women were no longer taking medications, there was a blood pressure difference. And by 6 months, this widened. And when we followed this woman when I joined the research group 4 years later, these 100 women have big differences in their blood pressure. So 7 millimeters lower in the intervention arm that would be managing their blood pressure compared to those that have been looked after by GP and midwives as part of usual care. Just to put that in context, if you can keep that going for the whole life, a 5 millimeter difference equates to a 20% lower reduction in risk of heart attack and stroke. So 7 is really impressive. And all of these were adjusted for the usual factors that affect blood pressure, like salt and exercise and smoking. So when I joined the group, we ran this trial called POP-HT. You can see we like Rice Krispies within our group. And what we did was we took 220 women, roughly split them into an intervention arm and a control arm. And we randomized 110 to have a blood pressure monitor given to them on the ward where they delivered. And they were given an app that allowed them to monitor their blood pressure and adjust the medicines guided by doctors. And the other 100 were looked after by their GP and midwives as per usual care within the NHS. We then followed them up with various tests. They had a scan of their heart at the bedside called an echo, and that was repeated at 9 months. They had blood pressure monitoring continuously in the intervention arm, and the control arm had a week 1 and a week 6 visit. And then at the final visit, they came up for almost a half a day with us, and we MRI'd almost their entire body, took bloods, put them on a treadmill, but it was a bike, not a treadmill, and repeated the echo and blood pressure monitoring. The study was very, very successful. Over 95% completed the trial in both arms, which is remarkable given how busy women are when they've got a new baby. This is a similar graph you'll recognize at the SNAP study. So what it's showing along the bottom is time after birth. Along the y-axis, their blood pressure. And then the percentage figures there are how many women are taking medications. You'll see that by 6 weeks, just over a third are on medication. By 9 months, almost all women are off. What we see is that the blood pressure starts to separate by about 6 weeks, much like the original smaller study, and then widen out to 9 months. And those are real world blood pressure that you would have at a GP practice or a clinic blood pressure. So the 131/86 would be hypertensive, and in the control arm on the intervention, it was about 5 millimeters lower. That key thing being that 5 millimeter difference. This is a 24-hour blood pressure, which is a gold standard. It's thought to be better because it removes the sort of nervousness that some people have, the white coat response. And it also allows a more detailed assessment over the whole day and night. And you can see here that the differences have been bigger, 6 and 7 millimeters between the systolic, the top blood pressure, and the diastolic. So not only do we look at blood pressure in this study, we also wanted to look at, does it affect women's quality of life after birth? Lots of women end up coming back into hospital, probably about a third of women in real life. And it's highly stressful because you get often separated from your partner and from another sibling if you have them. And often it's a 3 or 4 day admission. So we were really pleased to see that not only did we improve blood pressure, but we reduced admissions by 72% between the two arms, meaning you only need to treat 5 women with this technology to prevent 1 admission after going home. And that's really impressive, particularly when NHS maternity services are under incredible stress. The last bits I'm going to talk to you about here, don't worry too much about that detailed picture with all the numbers. I'm just going to explain what it means. And what we're seeing here is that women given a monitor, and that monitor there is just like the one they had, were either allowed to manage their blood pressure guided by us or looked after by GP advice. 9 months later, then we use their blood pressure better. But when we looked at heart using ultrasound, which is echo, and MRI, the hearts were less thick, less heavy, more efficient, i.e. they pumped better, but they also relaxed better. All those numbers in the bottom right there, these E primes are cardiology terms that we use to look at the stiffness of your heart. And we know that if your heart's stiff at 9 months, you're more likely to get heart failure and heart disease. So these are really nice beneficial changes that show for the first time that an intervention could lower parameters associated with long-term cardiovascular risk. I'm now going to hand over to Winnet to talk about the impact on the blood vessels and the brain in the same trial. Thanks for the slide, Stephen.
Thanks, Jamie. Yeah, so because we did that really extensive 6 to 12 month follow-up with all of the imaging and the bloods, we could look at lots of different things. So we also looked at the the vascular results. So we also saw that there's greater, it's called aortic distensibility. So basically your vessels are less stiff, so they're able to absorb the blood pressure a bit better. And then we also looked at the brain because we did brain MRI. And what we found, the main result was in the intervention group, the white matter volume was higher. So white matter is really all the connections in your brain. So if you have more white matter generally, you have very high speed information transfer. So you can just, the different areas of your brain can talk a lot more efficiently to each other. And in terms of aging, that really protects you from dementia and other sort of cognitive decline later on. Then there's an interesting sub-finding. So Jamie briefly mentioned there's different subtypes of hypertensive disorders of pregnancy. Generally, preeclampsia is thought of as a bit more of a severe phenotype, and we saw that the women in the control group who had preeclampsia had lower some of these subcortical brain volumes, so really sort of in the stem of your brain, the very basic brain parts. But we didn't see that difference between the different types of hypertensive disorders of pregnancy in the intervention group. And that suggested that the intervention was particularly good for the preeclampsia patients. So they didn't have as much sort of brain volume loss in those areas. So the overall conclusions of the trial, well, first of all, the trial was very successful because we showed that the period after birth is a very critical window to reduce longer term risks. And that really makes sense if you think about it, because in that time, a woman's body is really returning back to their normal state. So there's lots of changes happening. So therefore, an intervention has lots of potential effects if you can sort of guide that in a healthy state. And as Jamie said, the self-management intervention was safe, effective, and women liked it, which is also very important in terms of adherence. The blood pressure reduction really persisted long after the medication stopped, because that was only 39 days, and we saw the differences much longer after that. And as Jamie already mentioned, you only need to treat 5 women to already prevent 1 readmission. So that's a really good sort of health economic result. And in terms of the sort of organ changes and the real clinical impact, so it could, this 5 millimeter mercury difference could make a really big difference later on in life if that consistently stays that way, as it seems like it is, results in 20% reduction in lifetime cardiovascular risk. So that is massive. And it's not just the blood pressure that changed, was also all of these organs. So the heart indices that Jamie talked about are associated with reducing long-term risk of heart attack and stroke and heart failure. The blood vessel stiffness reduction is associated with lower stroke risk. And the brain structure difference, we don't actually know. I mean, we know that having sort of good white matter is better in the long run. But that is a little bit less well researched, how that would affect your long-term health. Now, I also wanted to tell you a little bit more about the hypertensive disease subtype. So this is a different piece of research that we've done even more recently. And that's because we so far, and not just we in this study, but actually generally in cardiology and hypertensive clinics, we always treat blood pressure as this one single thing. But actually, people with the same blood pressure can end up in vastly different clinical outcomes. So not only can some people have heart failure and other people have stroke, but people with the same blood pressure can have vastly different clinical outcomes. So why is that? We actually don't know. So that's what we set out to investigate. And our model for this was really, maybe we need to look, rather than just like one singular path to disease, maybe we need to look at hypertensive disease more of like a landscape. And I want you to imagine that the path in the middle of the valley is sort of like a route to healthy aging, or at least non-hypertensive disease aging. But any of those mountains can represent different adverse clinical outcomes. So maybe one of the mountains can lead to stroke and the other one to heart failure. So we went about researching this by using data from the UK Biobank, which is this huge national cohort. Lots and lots of people have undergone this very detailed MRI and all sorts of other measurements and bloods, and we know their medical history, and we know their height and weight and their blood pressures, etc. I won't go into the details of the modeling too much, but essentially what we did is we used a technique that only looks at hypertensive disease. So it's not a general model of all types of disease. And we really wanted to separate out those with severe hypertension from those who are, we call them healthy, but I will stress that they could be very unhealthy in different ways. They just don't have hypertension. So that our model is very specific to hypertensive disease. And we were able to make this model, and we treated it like a landscape. And essentially, we could place each individual in this landscape. And we can say, for each individual, okay, how far have you traveled up to any mountain? Which means how far have you progressed in your disease? And we call that the hyper score. So it's a score from 0 to 1, 1 being sort of very diseased, almost having a heart attack or any other clinical outcome, and 0 being like basically in the valley. And then the other one, we call them hypertensive disease progression trajectories. And that really tells you which mountain you've gone up to. So which subtype of like hypertensive disease have you got? So we found actually 5 distinct subtypes. For example, the first one is really predominantly around the heart. Second one was around more like metabolic, like blood lipids. The third one associated with blood vessel damage. The fourth one more about brain, and the fifth one heart and kidney together. And to link this back to the talk that we're doing today is obviously when we've done this, we've modeled all this hypertensive endocrine disease. So we wanted to know what women with hypertensive disorders of pregnancies, where do they sit? Like which path are they going to walk on the rest of their lives? Turns out they're actually represented across all of these different trajectories, which was a little bit of a surprise for us. I mean, there are some trajectories where they're more likely to fall on, but generally they were everywhere. And then we realized also not all hypertensive disorders of pregnancies are the same. So we did see that if you've had a miscarriage in your pregnancy or one of your pregnancies, you're more likely to be on the trajectory 3. If your mother had a hypertensive disorders of pregnancy and you did, you're more likely to be on the cardiac kidney trajectory. And interestingly, if you've had a female baby, you're more likely to be on the brain disease trajectory. Don't ask me why. We're still researching this, but that's just one of the things that we found. And then linking it back to the trial, because you can imagine if you have these different types of trajectories or hypertensive diseases that you could potentially go on or fall on, it could mean that you respond differently to the intervention or any intervention. So we wanted to see in the POP-HD study, sort of if women in certain trajectories responded better or differently to the treatment. So we actually found that everyone reduced their blood pressure, which kind of makes sense because the effect was so significant. So it made sense that everyone actually in the trial responded to the trial. However, we did find that there were differences in how your organs changed in response to the intervention, depending on which trajectory you were on. So, for example, those in trajectory 1, their heart ejection fraction, so basically how strong your heart can pump the blood, they increase the most. Whereas those in trajectory 3, the stiffness of their arteries reduced the most in response to the intervention. It kind of makes sense because that's the blood vessel trajectory. And then brain white matter volume increased the most in trajectory 4 and 3, which again kind of makes sense. But why does this matter? It really moves us on to the future of healthcare, and which is more personalization, not just of the interventions, so seeing which interventions work for whom and why, but also in terms of their long-term clinical management, because these women very often kind of get lost in the system because it's so hard to predict who's going to go on to develop severe disease later in life and who isn't. So if we can really monitor them early and see, okay, this is how far they've already progressed in that trajectory, and maybe even see over time how quickly someone is traveling along their trajectory, but also which subtype they are on. So you can really keep an eye on specific features of their disease. So that could lead to not only earlier detection of disease, but also better prediction of their risk and generally more personalized care. So with that final message, I'd like to thank all of our co-investigators and everyone who's worked on the POP-HD trial and all of this modeling. And thank you very much for your attention.
Thank you so much, Jamie Winnick. Really interesting and brilliant research. I'm just going to share my questions slide. We have a few questions that were sent in previously, which we can look at on the screen. And feel free also to add any questions to the chat. So the first question, Winnick and Jamie, if you're happy to answer, we've got some that came through initially on the registration form. First question is, does the degree of blood pressure control or timing of delivery have any correlation with later cardiovascular disease?
Can we say that one, Winner?
Yeah, clinical ones.
Okay, so there's some sort of two bits to that. So degree of blood pressure control, have any correlation? We think so. Our trial only had just shy of 250 women in, so we need a bigger trial, which has been done. It's imaginatively called SNAP2, and it's just analysing and following up the last 750 women. And that's going to help people be able to answer that. But in the early work we've done looking at this, the lower the blood pressure, it seems the better the impact you have on the remodeling of the heart, the brain, and the blood vessels. So we do think that lower is better. And lots of trials outside of pregnancy have shown similar things. Secondly, timing of delivery, that's slightly outside of our area, but there was a trial done, which was a big trial in the UK across multiple different hospitals, and it was called Phoebe, and that showed that if you deliver women earlier, and it doesn't unfortunately seem to have a benefit on their later risk of cardiovascular disease, albeit it didn't follow out beyond the year. And so that trial was a negative trial. I'm looking at early delivery babies versus current care.
Okay, great. Thank you so much. Our second question is, many women in low and middle income countries have limited access to prenatal care. What is one intervention that you believe could have the greatest impact on reducing complications related to hypertension in pregnancy?
Very good question. I'm not sure if you want to come on this one, Winnick. So obviously this trial was done in Oxford as a single centre, and the more recent SNAP2 has been done, again, it's a UK-based trial, but across a much wider demographic and range of IMD quintiles to try and capture more representation of the whole UK. And trials of blood pressure management in low and middle income countries have been done by Andy Shen, and he's shown certainly antenatally it can really make a big difference if you're using home monitoring to detection disease. And they found similar things after birth, not only for hypertension, but also for sepsis, which is really common over there. So I think that's, giving women the opportunity to self-monitor and educating them on how to contact and when to contact health professionals will make a massive difference. I think that, it's a simple intervention that can be easily taught, and they're not expensive either for these monitors.
Yeah, I think, definitely not my area of expertise, but the most sort of powerful interventions have been community driven into sort of how sustained the efforts are and what really works in those settings. And that means different things for every individual setting. But I think getting the community involved is really important.
Yeah, brilliant. Thank you. So we have a third question. Many women with gestational hypertension or preeclampsia return to normal blood pressure after childbirth. Despite this, they continue to face an increased risk of cardiovascular disease later in life. Based on the current evidence, should pregnancy be viewed merely as a physiological stress test that unmasks an underlying cardiovascular predisposition?
Want to take this one, Nick? I think it kind of feeds into what you were talking about in the second part.
Yeah, it's a very much an ongoing discussion. I personally think it's a little bit of both. The fact that we can make such a big difference in the postpartum period kind of suggests that it's not just a stress test and that everything just automatically goes back to their baseline. I think it does indicate that the pregnancy itself does something and that we can reverse that successfully if we treat better. But I definitely think that there's some to some extent, the pre-pregnancy health state is very important for the later cardiovascular health as well. I just want to add anything, Jamie, or are you nodding?
Yeah, no, I agree with that. And I think also, like you say, I think there's different trajectories. So there are women who get early onset preeclampsia where we think it's a placental problem rather than perhaps a heart problem. And often these women are running, 50 kilometers a week, have a BMI of 21, no vascular risk factors, and I think that this is where we start to understand now that it's not just one disease and there are these different trajectories and we shouldn't be treating everyone the same. And we need to follow them up in an individualized way.
Fantastic, thank you. And we have the last one on the screen. What are the biggest barriers to scaling the postpartum cardiac risk clinic model outside of Oxford? That's the first part of the question. The second part is, what can women who experience preeclampsia do right now to protect their brain and heart health if their local clinic doesn't offer specialised long-term follow-up?
Perhaps we could both take this one. I think, unfortunately, like many of the NHS challenges at the moment, is access to equitable care. In my NHS practice in London, we don't get half the same self-management set up, and it's the same things. It's funds to buy the monitors, research nurses and NHS nurses to support it. So there's lots of very, very driven researchers around the UK and different parts of the country, and there's lots of international interest in this area. So there are trials happening in Australia, New Zealand, and America as we speak on the same thing. I think that SNAP2 would help. When you have a big trial across 20-odd centres, it helps to change guidelines. But I think we just have to keep banging on the drum. And in the meantime, individuals have got to keep sharing and pushing for change at the local level. But to adopt it NHS-wide, unfortunately, it takes time. As we know, often interventions and trials will take 10 years to translate into clinical practice. So if you are one of these women who doesn't have access to the specialist clinic who's set up in Oxford, what you can do is, home monitor with a monitor that's validated, which you can see on the British National Hypertensive Society website. And you can, if it's slightly higher, ask your GP to arrange a 24-hour blood pressure monitor, and refer you, if that comes at normal, to a local cardiologist with an interest. And there are many of those.
Yeah, I think the beauty of this is it's self-monitoring. So in theory, even though obviously this was directly linked to titration with the doctor, you can actually self-monitor and keep your own health in mind. And then the other thing about protecting brain and heart health, anything that is generally recommended for brain and heart health, such as good nutrition and exercise, even if it's just movement, doesn't have to be like intense sports. All of the things that are recommended in the rest of your life still count, and they still matter, and they make a big difference to your long-term brain and heart health. So that's something that people can always do at home as well.
That's brilliant. Absolutely. Thank you so much for the recommendations and advice. Really great. Roy, over to you. Do we have any questions in the chat?
Yeah, you've had some good questions come in the chat. This one, first one's probably for Winnock. Is the change in white matter volume mainly an increase in fluid there? Were there any signs of inflammation?
Don't know if there were any signs of inflammation, but the cerebrospinal fluid was higher in the people that had lower white matter volume. But that also makes sense if there's more space in the brain. It just fills up, doesn't it?
We didn't see a difference in white matter lesions if we went, I think, on the T2 which is a sort of surrogate for edema. And similarly in the heart, I just get that slide just for simplicity, but we didn't see differences in scar when we used agents that can detect scar in the heart. In MRI, we didn't see differences using a technique called mapping that looks for inflammation and edema. So we think it's primarily a change in the heart muscle side, what we call myocytes. But we need to do more work on the brain.
Okay, the next question is, in the POP-HT trial, was there a difference in the types of antihypertensive medication between the two groups?
Very good question, Socrates. And so it was a randomized trial. We wanted to make sure that wasn't a factor that affected it. So we randomized them on receipt of what was the first line medication recommended in our national guidelines, which are produced by NICE. So in the UK, we use a medication called enalapril. And the guideline change came in 2019, and the trial ran between 2020 and 2022. So it was just creeping in to practice at that point, and about a third of the women were on it in each arm. And when we looked at the other traditional medications like the betalol, the nifedipine, amlodipine, there were no major differences in the groups. It was just that in the intervention arm, they had more medication use and they were titrating more aggressively in the first few weeks.
Okay. The next question, do you expect that this is a high impact opportunity window for preventing cardio and cerebrovascular disease risk in women, regardless of whether there was overt preeclampsia during pregnancy?
Shall I start with this one? I think yes and no. I think mainly no, because in a normal pregnancy, we do see that your heart kind of just reforms to normal, and that happens pretty remarkably well in normotensive pregnancies. It's really quite, quite impressive how the female body does that. And the reason why it doesn't work that way in hypertensive disorders of pregnancy is if you, during that phase of remodeling, and Damien can talk more about this, if that's happening under the stress of a high blood pressure, your heart adapts basically to that environment. And that's why intervening in this phase is so effective, I think. Whereas in a normal healthy pregnancy, that stress test isn't, like, that stress environment isn't or shouldn't be there. What could have a bit of bigger effects maybe, but this is not based on research that we've done or anything that I've looked into, is maybe postpartum weight gain, or if you don't lose that weight, or you have higher weight postpartum and you keep that weight on for the rest of your life, I do think that's a risk factor that you then carry on in the rest of your life. I also must say, in terms of, obviously you can do medication if you have hypertension, but in terms of if you're healthy, like, what interventions would you be doing this postpartum period? I mean, women are already working so hard to recover from their pregnancy. It's not like it's the time really to intervene or do lots of extra things if it's not necessary. I think if it's not needed, then let women just look after their baby, look after their health as best as they can. So other than just supporting good recovery, good nutrition, I think that would be the key thing. But not too much extra, is in my opinion.
Anything to add, Jamie, or shall I move on to the next question?
I think we covered that, and I think I think the weight signal is probably something we pick up on with some work between some Stalegy Fall and a new PhD student's about to start that work shortly, and so we'll be able to answer that hopefully in the next 3 to 5 years.
Okay, in terms of the different types of HDP, which I think is hypertensive disorders in pregnancy, if my Googling is accurate, did you see any trends in which type of HDP became normotensive without medication the earliest?
Did you have an answer to that based on your trajectory work? Did the preeclamptics or the gestational hypertensive return?
I mean, most of them were on medication anyway. In the trial, even in the usual care group, I mean, women are generally they were on medication, so I wouldn't know definitely without the medication. But yeah, it's not something that we've looked at, I don't think.
No, I mean, anecdotally, the early onset preeclamptics tend to normalize very quickly because now I think emerging evidence suggests it is placental driven, and once the placenta is delivered for that particular trajectory in that cohort, they tend to settle their blood pressures very quickly. There's a group of women who've had normal blood pressure throughout the entire pregnancy, deliver the baby, and then in day 3 to 10 after, their BP spikes wildly. It's called postpartum preeclampsia or fourth trimester preeclampsia, and that accounts for about 15 to 20%. And the worry with current care is because you don't have routine checks after going home, a lot of these get missed and then present really quite poorly. So that's again why empowering women to manage their own blood pressure and monitor it is great. Whether it's in a high or low or middle income country. But those people tend to have quite labile blood pressures for at least the first few months. And then I think the gestational hypertensive sort of sits in the middle, but it's a little spectrum of the same condition, to be fair. It just depends when you test their protein in their urine and, when you send a certain blood test off. And we sort of arbitrarily, as a medical profession, pigeoned people into cohorts where it's actually a spectrum of the same disease. but with different trajectories, as we're understanding.
Okay. Couple more questions. In your data, did 6 or 7 millimeters of mercury reduction of blood pressure after intervention bring blood pressure to normal after 9 months?
I think of when it puts, I'm not sure if you can go back to that slide, but I think the intervention still remain by modern traditional definition. So the old days, everyone used to think it was 120/80 was the best, perfect blood pressure. And we used to have 140/90 as the magic number. More and more countries have moved their guys towards 130/80. And I think the control arm were 130/186, so they were still hypertensive. We brought the intervention on back to normal, but still higher end than normal. So they weren't quite as good as a normal attentive pregnancy. And the 24-hour BP, I think it was 123/77. So pretty much normal, but ideally we'd like to get it even lower. But at the moment, the guidelines wouldn't support us doing that, so we couldn't push women to keep taking medicines and lower it even further. That's a trial for the future to see if you lower it for longer, does it make a bigger difference longer term?
Yeah, the 24-hour intervention group was actually 114/71.
Yeah,
24-hour blood pressure, so a
excellent.
little bit higher for the clinic.
Yeah, so yeah, that would be normal by any guidelines.